So we'll talk today about a consult for vasectomy. Before we start, do you have any question?
I do, yes.
Okay. Tell me your questions. Number one.
First one is how long afterwards for me to be able to, I guess, have a normal life?
Okay. So we say after the vasectomy for 1 week, no pushing, pulling, or intercourse.
Okay.
If your job is a sitting job, not include any running or jumping, 3 days is fine.
Okay. So I would have to stay away from work for 3 days?
They probably were going to give you a desk job for a week.
Mm-hmm.
But if we do it on a Thursday, you have a Friday, Saturday, Sunday off. Mondays you can go back to work, desk job.
Okay. How many, I guess, cuts or incisions are made on me?
I usually have one small one. One is about this big, and I don't stitch it.
Okay.
I'll explain that.
Okay. The risks to me, what are there afterwards? Like infection, I'm assuming, or?
So I've done hundreds of them.
Uh-huh.
Never had anyone had infection. It's really, that area is really hard to get infected.
Okay.
We'll give you a list of possible side effects. The one that comes to mind that some people might say, like, they might have some soreness in the area for a couple weeks after, because I do seal the tubes on both ends, and especially young people, if there's a lot of pressure of producing the semen's coming out of that tube that I locked up, it might be some build-up pressure, and that typically it will go after a couple weeks. Not much you can do to prevent it. Some surgeons, they like to seal the receiving end but not the giving end, so you end up spilling the sperms in the scrotum and the body absorbs them, but I typically like to seal both for accuracy.
Okay. How long does it actually take?
The procedure, it takes me from the time I start opening my packages and opening my stuff, about an hour. To you, it's gonna feel like it's 10 minutes, because I'm gonna give you in the vein medicine that will make you very sleepy. Not considered anesthesia, it's considered sedation. I give a mix of Nubain and Phenergan. In the vein, you'd be like kind of snoozing in and out of it. You'll feel like it's 10 minutes. When we're done, it's like, yeah, really? It's like, okay. And the comment that most guys say is like, that was so easy, I should have done it a long time ago. I don't know why I've been scared of it.
Right. Okay.
So no scalpel, no needle vasectomy, I started doing it in 2007. In residency, I was trained to do the same exact thing, except we needles and syringes to inject. So how do you open it? How do you open if you don't cut it? So if you imagine normal weight, I cannot do this procedure on an overweight, because your skin on the scrotum should be thin like this. If you're overweight, your skin on the scrotum will be thick like that, and my instrument will not work on it. So normal scrotum skin is thin like this, maybe a little bit like this, and that's doable. And the tube under in the scrotum is like almost like this. It feels like the tube like that. How I open it and how I get to the tube is we don't cut the skin. What I do is, like, I use a spring-loaded, it's called Metajet. It's a spring-loaded stainless steel pen that gets sterilized and used one time every time, and then I have to clean it and sterilize it. Load the numbing medicine and cock it like a spring and shoot it. It will shoot like a pressure washer, like a really high PSI, and it will penetrate the skin and the tube and get the area numb. Once, what I do is exactly, I hit 6 hits. I do 1, 2, 3, 4, 5, 6, and the area is numb. Then what I do after that is I have a loop, almost like a needle nose, but it's a medical one, and I hold the skin and the tube together. Once I hold it together, then I open the skin. How I open the skin is, this is the difference between cutting and not cutting. So if your skin is a tissue just like this, that if you cut the tissue, you're more likely to cut fiber and cut blood vessels, and you bleed. So the procedure I do is I don't cut. If this is the area I numbed, and I'm working on this area, and this area is numb. So what I do is, and this has been held by my tool, my loop tool, is this is numb, you don't feel any of that. I would stab it and then separate it. So what I'm doing is I'm separating the fiber. I'm not cutting them. And I separate them just about this much. It's like about less than a quarter of an inch. It's about
an eighth.
6 millimeter. That's a head of a pencil eraser exactly. I separated this much, just enough that I exposed the tube. I'm going after this tube, and this is the tube that's actual size. No matter how big you are, what size you are, this is actual genital, and this is the testicle. That's the vas deferens going through to the back of the bladder, going to the prostate, and coming through the ejaculate canal here. So this is another picture. Coming in, comes out. So I'm after this one here. So once I pull that tube out, then what I'm going to do is I'm going to clean this tube, make it squeaky clean, remove all these structures around it, the blood vessels and everything. After I clean it, I would nick halfway and nick here halfway, cut it halfway. And then I use one of these one-time use cardi. I will put through that cut half open, and I would cauterize it. See, this will turn red. And when I cauterize it, it will turn from pink to white, just like when you cook the egg, turn white. And then I do the same thing here. So I'm going to cauterize this area and this area. After I cauterize it, then I use an absorbable suture, and I'm going to stitch, not where I cauterize, beyond where I cauterize. Like I stitch on the normal tissue, not on the cauterized tissue. So I'm doing two modalities of sealing. I'm cauterizing and I'm stitching to close. And this one, it's like when you use a fish line, when you tie these things, they have a memory. You don't tie one knot. I typically do about 6 knots. So I'll do 6 knots, like tie it really as hard as I can, 6 times. And then I go a little bit OCD. Actually, I double tie on it. So I do another one. So I double tie here, another 6 knots. And then I come and tie here 6 knots twice. So you're going to have 12 knots here and 12 knots here. When I'm done, I cut this piece, take it out, and lift the scrotum skin like this, and the tubes will drop. And then what I do, the opening that I do on the scrotum, I do it in the front here, in the center about here. Then I move this tube on the right side, move it to the center, and through the same opening, I pull the tubes on the other side. So I really use one opening. I don't do one here and one there.
Right.
And then I repeat the same procedure here. All I do, the skin opening that I do on the outside, I put a little bit of base stration ointment and a pad just like this, and a cold pack. In the layer of the scrotum, there's muscles going this way and muscles going that way. So when we put the cold pack, it will shrink them close, and I don't stitch that skin opening. I just do that cold pack, and the only stitches you have are these absorbable sutures that the body will absorb them for about 3 months, and they will absorb them. When I first put them, they're like hard, just like a fishing line. They are hard, but within 24 hours, they become very soft, like silky. But because I put a lot of nod in there, you'll feel like nods or lumpiness, but that will disappear after they get absorbed.
And that comes after how long?
It disappears after
No,
a
I
couple
mean
months.
the feeling of the little bumps.
You might feel them for a couple months,
Okay.
the bumps. A question commonly asked is like, when I'm going to have ejaculates anymore after you do the vasectomy? The answer is yes. Your ejaculate, 45, about 90% of it comes from the prostate and the seminal vesicle. Only about 5 to 10% comes from the testicle. So when I'm cutting this and isolating the testicle, is only going to reduce ejaculate by this volume 5 to 10%, which is not appreciable by a naked eye. So it's still going to be the same ejaculate. It's not going to be a lot less that you cannot tell.
Right.
Another common question is like, is that going to affect my testosterone? The answer is no, it's not going to affect it, because the testicle is an endocrine and an exocrine gland. Exocrine gland is the part that comes out that we're cutting. That's the outside plumbing. The endocrine part, we're not touching it. The blood vessels that supplies the testicles come in, I'm not touching them, and you still have full function of the testicle, except you're not expressing the sperms out. What happened to the sperms? They get locked in here and they don't come out.
What happens to the 5 to 10% that's left down there? They just
The testicle quit making it and it doesn't come out anymore. And if you say, the other question is, can I do reversal?
right.
If you think of a reversal, I'll tell you, do not do the procedure. You're not a candidate for it, because yet first, a reversal procedure, there is doctors that will do it, but here's the issues with the reversal. Number one, insurance will not cover it. Number two, the surgeons that will connect the tubes together, they cannot guarantee that you will have a viable sperms coming out, because in our body, if I never had a vasectomy, my immune system never seen my sperms, and there's a sperm blood barrier that when I do any cutting and your body will see these sperms, it will end up making antibody against them in 50% of people and end up killing those sperms in the source. So even if they connect them, they cannot guarantee you get viable. I known some patients that they had vasectomy and they reversed it and they still couldn't get viable product. They end up doing direct extraction and IVF. I have one patient that he actually did an IVF. He had 5 girls. He wanted to have a boy, and he did an IVF, and he gets number 6 girl.
I guess for us, that men that we don't know, like we think whatever's left down there, like do they rot? What happens?
No, just the body absorbs it.
Oh, okay. So it just gets absorbed back in.
Yeah, it disappears. The body absorbs it.
What about complications later on? Like I've heard stuff like it increases your
prostate cancer risk.
Yes,
unfounded. There's no relation between prostate cancer and this. Before I do the procedure on any patients, I will examine their prostate and make sure it's not tender, because I actually had a couple months ago a patient that came in young, in his mid-20s. He wanted a vasectomy, and he had all the symptoms of prostatitis, and he had a very bad prostatitis. I told him, I'm not going to do a vasectomy for you until we clear it, because if I do a vasectomy on those people, see, prostatitis, this is the prostate. When you have a prostate infection, the infection will affect the seminal vesicle, will affect the tubing, it will go all the way down to the testicle, and they will have pain in the area, and they're going to blame it on the vasectomy, and they're going to say, oh, I have that problem, because it will make the pain worse. I had that problem because I'm touching an infected area and I'm tying and squeezing an infected tubes. So they're going to say, I had that problem since I had the vasectomy. So I don't want them blaming on their symptom on the vasectomy. I want them to realize that they have a prostate infection they need to clear, and if they have in the future, they need to focus on treating the prostate, not blaming a vasectomy that nothing you can do about it. Right. So I have a lot of patients, I actually delay their vasectomy because I have to clear the prostate infection. And they need to know that there's a strong relation between pain in the area and prostate infection that's commonly unknown and undiagnosed. You can go to all kinds of specialists and they'll tell you nothing wrong with you, but you have prostate infection. Are you sterile right after the procedure? Because we cut those tubes and we sealed it. The answer is no. Why? Because you are constantly producing sperms 24/7, not only during intercourse. You're producing sperms, and those sperms going through this tube, vas deferens, through the groin to the back of the bladder, and dumping here in this, I call it the holding tank, and that's called the seminal vesicle. That's the holding tank. So you have sperm sitting, live sperm sitting in the holding tank, in the seminal vesicle. And whenever you ejaculate, the ejaculate comes half from here and half from the prostate. The prostate supplies juices that help the viability of the sperms. So you have viable sperm. So we say after a vasectomy, I give you an order to do a sperm count analysis. You do it after 15 to 20 ejaculate. And the reason for the 15 to 20 is to empty your holding tank, to empty all the sperms. And since I have been doing vasectomy from 2007, I've never had anyone that came positive. I've never had any failure as long as they do it within the after 15 to 20 ejaculate, make sure they empty all their holding tanks. And a lot of time when the test comes, it might say couple non-viable sperms. These are old sperms that were sitting there not viable, and that's clear. Typically with each ejaculate, you have millions of sperms coming out.
I read something about that they can come back together or connect together.
So, good question. I recommend personally you do the sperm test after 15-20 ejaculate. I also write on it, if you want to be really paranoid about what is that 1 or 2 in 100,000 that they could connect. So nature could connect itself, and usually if that happens in the first 6 months. So I would say after 6 months, go do the test again.
Okay.
And that will tell you if nature connected itself somehow on its own. I have one patient that had a vasectomy done with a local surgeon, not because the local surgeon did anything wrong. Actually, that patient came in for post-vasectomy sperm analysis that showed he had sperms. I sent him back to the surgeon because it's considered a failure. The surgeon told me that that's one of the rare ones that he probably had a third tube because he cut 2. We don't look for a third one. We look for 2 tubes. I cut 2 tubes and done. I don't look for a third one because if you look for a third one, you're looking for trouble.
Right.
So, but if that person is actually that patient had a third tube, so they have to go look for the third tube to cut it. That's really rare. I haven't had that happen to me. So it's not a bad idea if you're really paranoid about what if nature connects itself. Repeat it after 6 months.
6 months.
And if you're good, you're good.
Will I need like
the same order I write on
right.
it. I write standing order, repeat in 6 months.
Okay.
I write it on everyone. This way it gives you the chance. If you want to repeat it, you repeat it. If you don't repeat it, it's up to you.
Right.
So for cash pay, we charge $1,500. For patients with insurance, because our insurance, the way we deal with insurance is you pay VIP, which is $300 every 3 months. But if you come in today and you have insurance we make you pay a year upfront, which is $1,200. We call it a high value procedure. So you pay $1,200 plus whatever the insurance want you to pay as a copay or a deductible. So it will actually end up being $1,500 if you have insurance or not have insurance. Because if you go do it locally with the local surgeons in the hospital will bill between about $10,000. So you will end up hitting your maximum out of pocket, which most patients, their maximum out of pocket between $2,500 to $3,000. My insurance maximum out of pocket is $7,000 for a person. So most of what I do, actually, most of the vasectomies I do are for patients that we don't take their insurance. They come and pay cash. It's $1,500 cash, and that includes follow-up or anything after related to the vasectomy.
And it's done here?
Yeah, in the other room.
Okay.
By myself, no assistant.
Right.
I just do it solo.
Got it.
So I take my time, and I would say I pride of saying, I take my time, take me about an hour, no rush, and I don't have anyone waiting on me. I don't have any patient waiting on me. I'll be like the last thing for the day that I do. I don't like to be rushed. I take my time. I listen to my music, and I just chill and take it easy.
Right.
Yeah, and when you're done, to you, it will feel like, wow, we're done that fast. Like, yeah, because I end up giving you medicine to sedate you, it will go really fast on your end.
And I won't be completely out, just a little.
No, you'll be talking to me. You might be snoring here and there, but if you can carry conversation, we talk, and you might tell me secrets and stuff like that.
Oh God.
Yeah.
Right.
The last patient we did, actually, his wife was watching. So if your wife wants to watch, I have no problem with that.
Okay.
This way, maybe you get some sympathy.
Got it.
Yeah.
All right. Oh, and obviously I have to come clean down there, right? Trimmed and all that.
So pre-procedure prepping, I give you 1 milligram of Xanax. I want you to take an hour before you come to the office to calm you down, because you have to be calm and not nervous. I will also give you a shot in the vein that will calm you down. But if you're very nervous, the scrotum shrink and I cannot work on it.
Got it.
And I will give you a prescription for Celebrex, 200 milligrams, to take 1 a day to reduce inflammation and pain. And that's the only medicine you take. And typically I say, take it for a week. After a week, it's up to you if you want to keep taking it or not. But I give you a prescription for a month. You can keep it for other. It's just like ibuprofen, but it does not increase the risk of bleeding or bruising. Okay. When you come, I want you to trim the area, the hair, with a trimmer, just like trim really short. I recommend not to shave with a razor, because shaving irritates the skin and it can cause skin infection. But if you trim just like very short, so when I do my knots tying, I don't tie the hair with it. It doesn't get in my way.
So trim everywhere. Don't shave.
Don't shave with a razor. I would say trim this area here. Okay. So trim the pubic area and all the scrotum with very short hair, like very short stubs, and nothing I can tangle my tying.
Got it. Okay.
And we will put on you a frozen peas. I recommend patient buy a couple frozen peas, put them in the freezer, and you put them not directly on your skin. I would say I wrap them with one of my surgery rags, just one layer, put it on the area to keep the area cold, because when it's cold, it will close the blood vessels and shrinks the muscles to close the area. Again, no stitching on the outside incision, closes, and you might see some bruising in the area. That's expected, like a bruising not bigger than a quarter. No swelling. And because I take my time, if there's any oozing or anything, I see it. I take care of it. It's not like a quick procedure. I'm done within. Some surgeons say, I get done in 20 minutes. You know what? I'm not in a rush. Because I'm not in a rush taking my time. If there's any oozing blood, I see it. But I've never had anyone that had any issue of bleeding or oozing afterward. Okay. No pushing or pulling or jumping after the procedure for like at least a week. Because when we tie these tubes, they're tied. If you do any jumping, you like whenever you do any tense your abdominal muscles, it will pull the scrotum and pull on those, and that kind of it's not comfortable. So no push and pulling. So if you do anything, if you say, can I work out? If like you want to do working out like this without closing your throat and doing any workout that you don't have to do, you're okay. But if you do any of that, you tensing your muscles and you're pulling up your tubes, that get it irritated. So if you want to work out without with your throat open, that's fine. Some people have the tendency, especially overweight people, have the tendency when they sit up, get up, do things like any of that, closing your throat and tensing, it lift and it irritate the area. So you can do anything as long as you keep your throat open and don't tense your stomach.
Got it.